Well, good morning. My name is Leslie Halpern, and I am an oral maxillofacial surgeon. I'm professor and section head of oral maxillofacial surgery at the University of Utah School of Dentistry. I also co-direct the Office of Women in Health, Medicine, and Science on the University Health Campus. I've had a very eclectic career, and I've had a passion for the topic that I'm going to discuss. Number one, because I lost my only sister through a violent crime. And number two, I spent the last 20 years doing research in this area, using my knowledge as an oral health care provider, as a medical doctor, and as a neuroendocrinologist. So today's talk is very exciting, not only for us as oral health care providers, but for us as a part of humanity. It's an epidemic in our backyard, which is intimate partner violence. And we're going to look at this in detail and how you as oral health care providers can be most pivotal in identification, intervention, and decreasing the risk of future injuries to our patient population. And even though this talk is really geared towards women victims, we're finding more and more that there is an increase in child abuse, as you know, elder abuse, same-sex abuse, transgender abuse, etc. So it really is a global public health epidemic. I agree that neither me nor members of my family have any financial relationships or commercial entities that may be relative to this presentation. The goals of this discussion is to first look at the epidemiology of violence and abuse with respect to intimate partner violence, particularly as it relates to you as oral health care providers, to our arena of dentistry within the state of Utah and in the US. We'll be looking at different evidence-based approaches utilizing diagnostic tools to identify patients who frequent our offices and to allow us to determine if they are positive with respect to exposure present or past for intimate partner violence. Most importantly, we as oral health care providers are most pivotal in identifying and providing total health outcomes for victims because most of the injuries, which I'll be repeating numerous times, are in the head, neck, and facial region. Finally, just some discussion of future directions for prevention and intervention. Well, let's start out at looking at a couple of definitions. Domestic violence and intimate partner violence. They are used interchangeably, and no one will fault you if you do. Either of them are an actual threatened physical, sexual, or psychological and emotional abuse directed towards a spouse, an ex-spouse, a current or former boyfriend, girlfriend, significant other. Common terms are domestic abuse, spousal abuse, domestic violence, courtship violence, dating violence, battering, rape, and human trafficking. And I'm going to speak a little bit about human trafficking, although not much in this talk, but there's some references that you can follow. The thing about human trafficking, though, is that it is really rampant in the state of Utah. As I said, the World Health Organization calls this problem one that is a global public health epidemic. It is a major public health and human rights problem throughout the world. And violence and abuse is one of three main health disparities in women, followed with cardiovascular disease and mental and reproductive health issues. So the World Health Organization has been really following this over a number of years. They state one of the most common forms of violence against women is that performed by a husband or male partner. And again, as I told you a little while ago, we're finding more and more same-sex abuse, transgender abuse, etc. Greater than 1 in 5,000 to 1 in 10,000 children under the age of 5 years dies each year from physical violence. And this comes out more and more on reports in child abuse data that is globally collected. From 2013 to 2017, and these reports usually follow 3 years behind, there has been a global plan of action to address intimate partner violence against women, girls, and children. And as of 2017, the consensus statement from the World Health Organization is that violence against women is a violation of a woman's human rights. 1 in 3 have experienced abuse by a partner, and violence and abuse affects the lifespan of victims in terms of their physical health, their mental health, and their sexual well-being. So in order to understand the problem, let's take a look at the epidemiology of violence and abuse, and we'll look at it in terms of child abuse, domestic violence, and elder abuse, and LGBTQ, just to mention. So for child abuse, the NCAN system database, which is the National Child Abuse and Neglect Data System database, usually, again, has a lag of about 3 years. So the latest data is that on the average, there's almost 3 deaths of children per 100,000, but greater than almost 700,000 victims per year, with greater than almost 4 million referrals. Boys, 48%, girls, 51%. It is severely underreported, and the prevalence rate, since you can only measure this at one point in time, we can't use incident rate, we have to use prevalence rate for this disease. There's about 1 in 6 identifications in the United States. In 2015, the fatalities were almost at 1,600, and as of 2017, over 1,700. Utah, and it's important that you know this, is the 8th highest in the United States, with 6,900 cases, over 27% sexual abuse. And for those of you that are interested, you can write down this website, which is preventionofchildabusutah.org. Now, surprising or not surprising, mothers are the perpetrators around 80% of the time, and which, you know, as I said, may not be surprising, especially if there is abuse going on in the house, since children will either witness it, be a part of it, and grow up to follow suit. And we'll talk a little bit about that later. Neglect is the most common underrecorded form of fatal mistreatment. And those of you out there who have seen children will evaluate a child, and the child may have an abscess in either a deciduous molar or in their first molars, and you want to see them back, and then they get lost in the system until they come back and the tooth has to be removed. And I've seen that in many cases in my own oral maxillofacial surgery practice experience. The biggest criminal result of this is the lifetime cost and burden with child abuse, which has come to be around $124 billion and increasing. We'll talk about the economics in a moment. This is very interesting. I don't know if you like history. I'm a history person. The landmark recognition of child abuse was dated back to post-Civil War time in New York, and it is the story of little Mary Ellen McCormick, whose father died in the Civil War, and her mother and her went to live in New York in a tenement. Her mother remarried, and she went out to work, and the husband went out to work, and Mary Ellen was watched by a surrogate parent during the day who severely abused her. And if you take a look at the picture on the left, you see that she was cut up severely, and there's a pair of scissors on the floor. Well, the tenement people would always have church volunteers come to their houses to bring them food, and one of the church workers saw little Mary Ellen and notified a friend, a Mr. Henry Berg. And those of you who have dogs and cats and all kinds of pets would know that Henry Berg is the father of the ASPCA. Well, Mr. Berg brought this into court in support of Mary Ellen's safety, so that in 1874, there was the establishment of the New York Society for the Prevention of Cruelty to Children. And this was really the start of the support of victims of child abuse. And now child abuse is reported in 50 states and around the world, and it is mandatory reporting. The picture on the right shows that Mary Ellen lived to a very ripe old age of 96 and had a family and a husband that treated her superbly. So this story ended on a happy note. However, the majority of other stories do not. And as I said at the beginning, violence and abuse is a global public health issue. It's a chronic, debilitating, and sometimes fatal disease. And there are so many different reasons why victims of abuse stay in relationships with their perpetrators: economic control, not wanting to leave because of children. And just a quick story as an aside, when I was an oral surgery resident, I trained in New York at Lincoln Hospital in the Bronx. We were about a block from Yankee Stadium, and many times there would be people coming in who were assaulted. And this woman came into the ER one evening while I was on call, and her husband had box bladed her face because the New York Yankees had lost, and he didn't like what she made for dinner. Well, it took me about 4 hours to suture this patient, and I did say to her, you know, you do not have to return home. And she said, no, my husband didn't mean it. I want to be with my children, etc. Well, the patient left with a referral to social services. And 3 days later, I was on call again, and the ER doc said, Dr. Halpern, could you come with me to see Mrs. So-and-so, who you took care of a few nights ago? Of course, I thought that she became infected and I did not do a good job. He took me into the trauma room, and she was on a gurney with a sheet over her. Her husband basically finished the job. He ended up being arrested, and I would imagine he was tried. But at that point, I wanted to give up being a doctor because I thought I failed my patient. But this type of problem is one that can be either very easy to diagnose and intervene or very difficult, and I will show you how. I'm sure everybody who is listening today has known someone who has been abused or has been a victim themselves. So to continue with the epidemiology, looking now from child abuse to domestic and elder abuse, with respect to domestic violence, which is the age group around 18 to 64, greater than 3 million adult victims are identified annually. Over 8 million are women, and there's more men now, greater than 4 million. We look at the female data more because that data is in a lot of the judicial data for homicides. If you look at the LGBTQ population, which is really ramping up right now with respect to being victims, unfortunately, of violence and abuse, the men are at 24, the women are at about 41%. Bisexual women are almost 3 times as much to be abused when compared to heterosexual women. And again, in the state of Utah, 42% of homicides were due to domestic violence within the last few years. 88% were male perpetrators, with almost 40% who are repeat offenders. If you look at the prevalence rate, it is very severely reported, 1 to 6% in the emergency departments at any one time, but the actual estimates are really increased to about 35%, but still underreported. 1 in 3.75 women, 1 in 7 men across the United States. But again, in Utah, 1 in 3 women have been identified. And Utah has a law, the 62A3305 law, that's zero tolerance of any suspicions. You notify Adult Protective Services. And the number is 1-800-371-7897. Again, 1-800-371-7897. And I have another number for you that I'll talk about in a little while. Now, with respect to elder abuse, as child abuse is mandatory in reporting, so is elder abuse. And I've played a role in writing that health policy serving as a liaison through oral surgery and dentistry to the National Advisory Council on Violence and Abuse of the American Medical Association. And the elder abuse mandatory reporting came out sometime around 2008, 2009. In 2016, with respect to elders, 1 in 10 or more reported themselves to be victims of emotional, physical, or sexual mistreatment or neglect. This is severely underreported at a 10% prevalence rate. Women are greater than men, which kind of makes sense, since if you look at the longevity and actuary tables, women do live longer than men. And there are different risk predictors: social, financial, psychological, special needs, nursing homes. A family member is the most common perpetrator. And as I said, there's mandatory reporting. So, you as practitioners are going to see more and more of the geriatric population, and many times they will come with a caregiver. So just try to be a little hypervigilant if you aren't already, and I'm sure you are already being hypervigilant about this issue. So this is just the poster from the state of Utah to just remind you that the hashtag is hashtag Utah 1 and 3, or Utah Domestic Violence Coalition, udvc.org. And you can call them. They're 1-800-387-LINK. And this will give you information about what is going on in your particular county. And I must tell you that how quite surprised I am. I moved to Utah 4 years ago to take the position that I'm in presently. Prior to that, I spent 5 years in Nashville, Tennessee as a residency program director in oral maxillofacial surgery. And I noticed even in Tennessee and Nashville that these numbers were quite similar. So this is just a terrible problem. And with relation to that, COVID-19 has, as a pandemic, given rise to a second pandemic. The pandemic of increases in domestic violence complaints that the police departments across the state of Utah has been seeing. And I call this a tale of two pandemics. And this is a news item that you can look at in the different newspapers of your respective cities. So healthcare and social care and community care has really stepped up to the plate in realization of a second pandemic due to a first pandemic. And part of the risk predictors of a pandemic of domestic violence rise in relation to COVID-19 is an increase in violence that has been perpetrated against certain healthcare workers, quarantine and social isolation, economic dependency because people are out of work, exposure of increased social coercion because of the interactions that people have at home behind closed doors, an inability as such to escape from the perpetrator, with resultant exposure and exploitation of relationships. What isn't listed down here is what is really being not measured within the family dynamic. There's been reports that during the COVID-19 pandemic, there's been a decrease in reported child abuse, which is kind of intuitive since many of these children are not in school. So teachers, workers, advocates who've been trained to recognize certain situations are not seeing these victims. So it is so important to, again, realize that one pandemic can really give birth to another. And this is what we see that is happening in Utah right now. The human trafficking issue is defined in the state of Utah as forced labor and or forced sexual exploitation. I serve on the Utah Trafficking in Person Task Force that's based at Children's Hospital. And we have an interprofessional collaborative working together, looking at children under the age of 17, as well as young adults and adults greater than 18 years of age. And we've developed a series of algorithms. I'm not going to talk about this in detail because this can take up a whole hour lecture, but I wanted to make you aware of it. And if those of you have an interest in human trafficking, you can contact the task force here at 888-373-7888. Or, yes, it's 888-373-7888. Now, as oral health care providers, I found this to be so, and I'll just say this about human traffickers. Many times they are going to show up at the dental office to have their victim look better, with a better smile. And many times you'll see a young woman come in, or a young man feeling very not at ease sitting in the dental chair unless that person who came with them are with them in the room, because they're not sure what to say. They're afraid if they say something that they're going to get caught, etc. So I would advise you that when you see certain patients come in with young teenagers who come in with someone that says they're a relative and is not an immediate family member, that you should maybe think to yourself, can this be a victim who is being trafficked? So again, I'm not going to talk about this much anymore, but it is a very exciting topic, and I suggest you contact that phone number if you are interested in learning more. So now, with all of this epidemic, it cost money, and I gave you some money, but let's look at more specifically the economic impact of violence and abuse. And as I said, I served on this committee through the National Advisory Council, and the National Advisory Council on Violence and Abuse gave rise to another association called the Academy on Violence and Abuse. And they are a very exciting interprofessional collaborative who would love to have more membership from oral health care providers, since we are most pivotal, as you will see, in diagnosis and interventional strategies. You can look it up on ava.org, and it's a very exciting organization to learn more about these topics. So in the USA, as of 2016 to 2018, the direct cost of the economic impact on violence and abuse has been about $12.6 billion, with indirect mental health care costs greater than $4.1 billion. The Institute of Women's Health Policies characterized these indirects as $9.3 billion as of 2018. I give two state examples because, as I told you, I spent time in Tennessee before moving to Utah. And if you take a look at the numbers in Tennessee now, it's up to about $50 million in healthcare costs, whereas between 2011 and 2017 in the state of Utah, it was greater than $92 million on people who have been perpetrators to be treated versus $16.5 million spent on victims. All of this money being thrown out as Band-Aids, totally not cost effective. Again, a lot of this money seen most recently is an increase in human trafficking due to an influx of refugees. And again, Utah is rampant with this. So, intimate partner violence is a dental, a medical, and a surgical issue. Oral health care providers, and again, I say this so many times, are so important in the link of good identification and interventional strategies, because as much as 75% of physical abuse involves injuries to the head, neck, and face. Intimate partner violence, as I will show you, has long-term negative health consequences for survivors, even after the abuse has ended. They are characteristically victims of poor health, poor quality of life, and a very high user of health services, as the dollar numbers have shown you. HMO data, public hospital data has shown this, and the numbers are just increasing. In a recent multi-city study of femicides, 41% had been in contact with their healthcare provider prior to their death, and only 3% accessed advocacy or shelter programs. Community healthcare providers are in routine contact. We are all in routine contact with affected patients, and we have the power to do something to help them. With respect to our professions, there are, of course, consensus statements. The latest one was from the American Dental Association in 2006, which stated it is imperative to educate the dental community and make them obligated to recognize signs and symptoms of family violence and abuse. As I told you before, I still am the liaison of the American Association of Oral and Maxillofacial Surgeons, and the Board of Trustees, after joining these organizations, came up with this consensus statement to state that oral and maxillofacial surgeons are dedicated to the health and well-being of all our patients, including those affected by violence and abuse, post-traumatic stress disorders, or traumatic brain injury. And just the caveat to this, with the number of men and women who went off to fight way back in Desert Storm and the Iraqi conflicts after 9/11 and the Iranian conflicts now, etc., are coming home and becoming violent perpetrators of abuse to their immediate families. And the Army, the Navy, the Marines, the Air Force now are developing programs to educate their doctors and workers to this problem, as well as the victims, in order to help them and save healthcare dollars. In 2011, the National Advisory Council, which became the Academy on Violence and Abuse, developed a set of core competencies across all healthcare, looking at the healthcare system, educational institutions, and the individual learner to both identify and intervene in their patient community. And I'll show you that later on in this presentation. As a researcher, and I'm an academic surgeon besides being in the OR, for the last 20 years, I became dedicated, written grant proposals, and have published numerous articles on looking at the relationship between facial injuries and intimate partner violence. And when I was in Boston, I developed a protocol with my mentor looking at head, neck, and facial injuries and a verbal questionnaire that gave us a high sensitivity and specificity for ruling in IPV-related injury etiologies. So as I told you previously, the head, neck, and the face is a common target. There's a lot of hitting in the face because a woman's face is the most meaningful area. My OBGYN colleagues and I debate all the time because it's very easy for a perpetrator to kick his victim in the abdomen while she is pregnant. So absolutely, hitting in the abdomen is another area of control. But we as oral healthcare providers realize that hitting in the face is a very powerful control factor. So surgeons and other healthcare providers who deal with the head, neck, and face are in a unique position to identify victims and refer for safety planning, information and support services, and advocacy, depending upon our victims' needs and choices. Some of the research I did was to look at cases across the country, and I co-authored a chapter with my colleagues about the epidemiology of maxillofacial injuries. And there is indeed a paucity of data, even now in 2020. We're still looking at this. We're still finding better ways to identify. What is more important from my perspective, and maybe yours, is that when we see a lot of patients, and they come to our office, many of them do not look like they've been beaten up, but that doesn't mean they haven't been abused. So it begs the question, are there any other risk predictors for present or past exposure? of intimate partner violence. And indeed, there are. A work done by Dr. Jacqueline Campbell at Johns Hopkins Hospital in 2001 and 2002 took a look at the health effects, long-term, of intimate partner violence because the lifespan of victims are shortened due to health consequences. So with all her research, and then I've done several studies afterwards, shows that intimate partner violence and violence and abuse in general are associated with the exposure or are related to causing 10 common chronic illnesses. There are physical effects and there are mental health effects. Physical effects include headache, stress, abdominal pain, chronic facial pain, temporomandibular disorders, sinusitis, dental disease, and cardiovascular diseases. And I've looked more closely at some of those, and if we have time, I will discuss them. The mental health effects are not surprising: post-traumatic stress disorder, depression, anxiety, substance abuse, and suicide, as well as the impact on ethnicity and race. And many people think that violence and abuse is related directly to socioeconomic status, but that really isn't true, because the socioeconomic status has absolutely nothing to do with the victim's exposure to the perpetrator with respect to control using physical and mental abusive strategies. As an example is, many of you who take care of adult patients will have a woman or a man walk in your office very well dressed, looking terrific in the head, neck, and facial region, no obvious symptomatology or clinic presentation of being abused, but this particular person has a health history that is very involved and goes from doctor to doctor and asks, why can't anyone figure out why I feel the way I feel, whether it's about my appearance, about my affects, about my ability to socialize with people, etc. And this is the kind of patient that you will see who is indeed a victim of prior abuse, which has long-standing effects, as I will show you, or immediate abuse. So how can we, as oral and medical healthcare providers, help our patients? Studies have shown that abused women want their providers to query them about intimate partner violence and its side effects. Asking is an intervention. Simply making a connection between their life history and previously incomprehensible symptoms may have a significant therapeutic effect. Again, injury location, oral health care is pivotal. So I had given 2 webinars on this topic last year. I don't know if any of you are members of ADEA or happen to go on the ADEA site. And what I did was I queried our audience nationally and asked several questions that I'm going to ask you, and I'll tell you what their results was. Does your clinical practice have a questionnaire that asks about exposure to violence and abuse? And the choices are yes, no, or I'm not sure. And many answered no, and I am not sure. So hold on to that for a moment. Family violence and dentistry kind of go hand in hand. Because a 1998 national survey revealed that 16.7% of women who sought health care for rape injuries visited dentists. 9.2% who sought care for physical assault by a partner also saw a dentist. Routine dental visits, ergo, may alert dental professionals to evidence that patients are being abused and lead to early intervention by the doctor. In 2008, victims stated that when signs were present, 88.6% of dentists did not ask. And that is so very important because obviously, why don't people ask? This begs the question then, to screen or not to screen everybody that comes in to your office. Screening by healthcare professionals increases identification, and many women and men do not object to being asked. Hypertension, for instance, is screened constantly in the oral healthcare provider's office. In fact, many more healthcare providers diagnose hypertension on their patients before or even when they had previously seen their primary healthcare physician. And that's pretty impressive. But what about screening for violence and abuse? So in 2002, a study showed that most health professionals surveyed do not agree with screening of women in healthcare settings because insufficient evidence had existed to show whether screening and intervention will lead to improved outcomes. Therefore, screening was not justified by the current evidence in 2002. In 2013 and in 2016, a systematic and meta-analysis review was done by the Cochrane Database Systemic Review Board, and they are the organization that many of us who are researchers go to help develop diagnostic questions that we ask in our research projects. So what they found is that screening is likely to increase identification, yet rates of referrals for intervention are low. So we can screen and identify, but what is the long-term benefit? And I like to call this the so what effect. You identify, so what? Well, looking at family violence in dentistry, abusers will often avoid the same physician, but they do return to the same dental office with their victim. And that is usually because they don't think we're going to look any place beyond opening up their mouth and doing what we have to do to make them look good and feel good. Children are more likely to have regular preventive care at the dental office. And again, I said I was going to repeat this, as much as 75% of physical abuse involves injuries to the head, neck, or face. Taking all of this into consideration and look at what has been done and suggested in the field of oral health care, JADA, the Academy of General Dentistry, and then JADA again put out a series of articles on the dentist's role in responding to the signs of intimate partner violence, of domestic violence, and once identified, how do we treat patients who have been exposed and have survived the trauma. And many hypotheses came about, some that I will discuss. Before I do, this was another question that I threw out to the audience. How many hours of intimate partner violence training curriculum have you experienced either during dental school or as a continuing ed course in the community as a lifelong learner? Because of course we all are lifelong learners. And most people either answered A or B. More B than A, but breaking down, many had no more than about an hour to 2 hours of CE in training in this particular area. So this begs the question then, as I stated, why aren't all of us in our practices? And this is not only in oral health. I don't want you to think that we're the outlier here. This happens still with primary care providers. It happens in subspecialties. It even happens in psychologists and other sociological specialties. There are barriers for identification based upon lack of proper educational curricula. So the training of healthcare providers have been insufficient even when the signs of abuse are present. And I showed you that on the data before. Inadequate education and approaches. Barriers to questioning, mostly because patients are accompanied by their partner or perpetrator, family members, etc., so they really can't speak. Cultural norms and personal embarrassment by the doctor. Cultural norms because the victim will say, well, my grandfather beat up my grandmother, my father beat up my mother, therefore my significant other can beat me up because that's how it is in our culture. Personal embarrassment by the doctor is usually one of two: fear of litigation if mistaken. And I will tell you again that child abuse and elder abuse is mandatory. You're better off with false positives than false negatives, and no one will sue you. If you do not report in a mandatory situation and someone else picks it up, you can be liable with fines. Your malpractice can go up. You may lose your malpractice, and you may lose your license to practice. One that I find quite interesting, that on interviewing many of my colleagues and my residents and my students, is something called secondary victimization. And what that really is that the questioner, the doctor, he or she may themselves have been a victim and do not want to ask about it because it will bring up bad memories to them and affect their ability to perform the way they must to maintain the fiduciary trust that their patients have in them. So risk predictors, then, when you look at it, can be physical, they can be psychological, and what are they? A very interesting study was done in JADA in 2018 by Parrish et al., who looked at intimate partner violence screening based upon educational exposure nationally. And what her data showed was a need for dentists to maintain professional responsibilities to screen and work with referrals via developing greater learning opportunities with respect to their professional role. And by learning different ways of asking questions and tutorials, they can increase their ability to identify victims and have them referred for intervention. Many schools that I will not show you, but data that I have, is that they're starting in the D1 year to give their students pre and post tests on their knowledge about violence and abuse in their patient populations, what the national data is showing, and how their role can be very valuable in greater identification and prevention of future injuries. And I know this is going on now in places. I'm a graduate of New York University College of Dentistry, and I was there from 1986 to 1990. I did not have one course in teaching me how to identify victims of violence and abuse. It was only when I was a resident, we had a 1-hour course in New York State on child abuse identification. So I will show you several courses that are available that you can do as lifelong learners, and some of which we are doing for our students. One particular course that is available nationally and internationally was crafted back in 1992. It's called PANDA. Some of you may know about PANDA in your respective schools or in your community. PANDA is the acronym for Prevent Abuse, Neglect Through Dental Awareness. And it was developed by Dr. Lynn Mood and Douglas, who is now a VP in a very large Medicaid, Medicare insurance collaborative, but he was the leader with Delta Dental in Missouri in developing this particular program. Again, it is located nationally and internationally, and there are representatives available in different states to give this course. The PANDA curriculum is based upon a series of contributing factors that deal with violence and abuse. First of all, violence and abuse is a learned behavior. Many abusers may have been victims themselves. Patient history. Does the parent and child, or perpetrator and victim, give the same history of an injury or a history of a present illness? Documentation. The beauty about being an oral health care provider is that we can remove the patient who is the victim away from their perpetrator to do imaging in another room, because they cannot go into that room with the victim. Also, we take photos. I mean, oral health is all about aesthetics and function. We have records of photos and clinical findings. Now, the legal and liability issues, as per PANDA, is based upon confidentiality and reasonable suspicion. Again, if you have a reasonable suspicion that this child is being abused, or even an adult, you report it. The worst case scenario is that it is a false positive and no one will be able to sue you. It is the false negatives that can get you into trouble. These are several pictures of cases of children that have been abused or neglect. And neglect of oral health care is the biggest form of abuse. I'm going to start with the upper left-hand picture because this was a child that came in from an unrestrained motor vehicle accident with mid-facial injuries. But what allowed the positive identification of abuse, and you may find it very hard to see on the chest, there are 3 cigarette burns. This child was indeed a victim of abuse. You look at pictures like this with poor health, pictures like this, neck marks around the neck of a child, a tooth that was knocked out, and the parent tried to glue the tooth back in, torn frenum. Many times these children will have a history of a sports injury. Something though like chronic pulpitis, decayed teeth, worn down teeth, injuries like this or like this, it is not usually a sports injury. So you apply open-ended questions. I see that you are injured here. Can you tell me what happened? Many times after making the parent feel comfortable, especially with the parent will admit that something had gone on at home. And you then can refer for social services. What you don't want to do is you don't want to look and be judgmental and go, I see your child has these symptoms. Are you abusing your child? Are you neglecting your child? Your child cannot be neglected. He or she has to come in. You cannot approach it that way because you will get resistance. You will then get into trouble because you are negating the whole purpose of why you have developed the fiduciary trust in the first place. And just another quick story. My friend Catherine Kramer used to be the head of the California Dental Association, and she had a father and a son who came in on a 96-degree day with an abscess tooth number 3. And the father was sitting there with the son, very fidgety. The son, in 96-degree weather, was wearing a flannel long-sleeve shirt with very heavy jeans and these dark Doc Marten boots. I don't know if any of you have children who have Doc Marten boots. I had a younger son who had Doc Marten boots. They are the boots that go all the way up with the laces. Okay, be it as it may, my colleague felt something just wasn't right. She had the child come in to have x-rays taken. The father was sitting out in the waiting room. And then she said to the child with her assistant, you must be very warm. Why don't you roll up your sleeves? Well, the child rolled up his sleeves and they saw that on both his wrists, he had red marks that looked like he was being restrained. Well, they ended up reporting this father with the child. They reported it to Child Health Services that same day, and they went to the house. They found that the father had the child restrained in a dog cage because his wife had walked out on him and wanted a divorce. So again, you have to look at the situation and see the patient as a whole and not just hone in on the acute problem of why the patient is present. Typical inflicted injuries that you can see on children are contusions, burns, bites, injuries that are healing in different stages of colors, lip lacerations, frenum injuries. Extreme fear of the oral exam is a very big symbol that abuse could be happening. Extreme fear. Temporal mandibular disorders is quite interesting. I had a young adolescent obese woman come in because her jaw was locking. And looking at her x-rays and her clinical exam, I wasn't convinced that she had a closed lock due to a dislocation, because I wondered how was she able to function every day, taking nutrition in, etc. I sedated her, and upon sedation, her mouth opened up quite easily. She did not have a displaced or internal derangement of her TMJ discs. Found out later that she was a victim of an incestuous relationship with her brother. So again, walking in, looking at the patients, you may not see these things at the onset, but if you think about it in a broader spectrum, you may be able to determine that these patients are indeed victims. And again, neglect is the most common form of child abuse, and that we always have to remember. So we have all of these ideas. So how do we bring them to the office? Well, you need to feel comfortable with your staff to discuss abuse and neglect at all staff meetings. You can provide clinical articles and information to all staff. You should have some of posters from the state of Utah, especially hanging in the workrooms, along with the labor laws that you have hanging in the workrooms. You have to encourage your staff to discuss the concerns about a patient, of course in private, but you have to also realize that members of your staff themselves could have been victims of traumatic experiences and are suffering from secondary victimization. So thinking with all that, you also must keep reporting phone numbers handy. And in Utah, the Division of Child and Family Services, the number is 855-323-3237. Again, 855-323-3237. And I will say this again at the end of my presentation, that I have my email for you to contact me of any questions or numbers, etc. Something very important that I am a part of right now in my own research of looking at victims is being part of an established team collaborative of trauma-informed care. And in 2014, Raja et al. Came out with a cover story in JADA relating to how the oral health care provider can be part of the trauma-informed care collaborative. We have to understand that trauma, number one, could have occurred early on in their life or the other day, or they are being traumatized currently. So we have to understand the impact of traumatic stress and health on our patients. This framework of understanding how trauma can cause stress-related physiologic mechanisms, and I'll show you that in terms of the brain in a little while, and how that can affect overall health. Being able to understand this framework should decrease the risk of re-traumatization, as well as contribute to recovery from traumatic stress. We have to be able to understand that neurological, biological, psychosocial, and social effects of trauma and violence can irreparably damage our patients. We have to be able to develop communication skills, form interprofessional collaboratives with our colleagues in the community. And now the buzzwords in oral health care are, as per Dr. Richard Valakovic, if any of you have had the privilege of hearing him speak or of knowing what he's done for oral health care, he has co-developed the interprofessional collaborative approaches, showing that oral health is part of the overall health and well-being of our patients. Our role of healthcare providers is to understand that premise. We have to be able to communicate, to have our patients know it is not right how you have been treated. You are not at fault. This is wrong, and I want to do something to help you. And by developing an interprofessional collaborative with your colleagues in the community, you can do that. And I do know that there are many continuing ed courses offered at the ADA and on the regional level that helps us to learn how to be better collaborative colleagues in the health and well-being of those we have the privilege of serving. Now, I want to turn my attention for a second to some evidence-based diagnostic tools that you can utilize, whether in your health histories or that you can find as tutorials. Now, the gold standard for identifying victims is indeed self-report. You can ask a patient, are you a victim of violence and abuse? And they can answer yes and no. But they will not often give you that answer. However, victims want to be asked. We have to be able to identify risk factors that we will ask them via the use of certain tools. When we identify them, how do we answer or find a solution to the so what effect so that we can have appropriate referral and intervention? By doing so, if we can, we will decrease the risk of future injuries. At the dental school level, just for a moment, since I'm section head of oral maxillofacial surgery, as I told you, and I'm working with my colleagues at the dental schools, at the medical schools, and even in residency programs to develop curricula and continuing education. In 2009, the question was asked at a panel I served on, do dental professionals face the same challenges and barriers to addressing violence and abuse in their training programs as our medical school colleagues? And working with our colleagues at the table at different panel discussions, we came to the consensus statement that there is recognition in both dentistry and medicine that oral health directly impacts systemic health, and each profession's academic community should address the role that oral health education ultimately plays in patient care. Now, those of you that went to dental schools that had classes with the medical students may or may not have had the good fortune to have seen how oral health melded with overall health, but now we are making a concerted effort to do that in our dental and medical school curriculum. And intimate partner violence, violence and abuse, child abuse, elder abuse, transgender abuse, LGBTQ abuse forms a very big part of this curriculum under a larger heading of sex and gender in health education, which would be a wonderful lecture for a different time. There is a tutorial that was developed at UCSF School of Dentistry by Dr. Barbara Gerbert and her colleagues called the AVDR Tutorial for Dentists. And this was based on a pre-questionnaire study that showed that dentists felt there were significant barriers to screening for domestic violence. So this AVDR tutorial was developed by Dr. Gerbert and her colleagues to help patients be approached about this topic without imposing unreasonable expectations that the dentist will solve all the problems. You know, we're not here to solve all the problems associated with family violence, but we need to be a major player in the link of the chain of events in helping to deter future violence. So several articles have been published in JADA about the AVDR. A is asking patients about abuse. B is validate, providing validating messages that acknowledge that battering is wrong when confirming a patient's worth. You are not at fault. What is happening to you is not right. It needs to stop. We, as oral health care providers, as I told you, document signs, symptoms, disclosures of the patient's record by radiographs, by photographs, and finally, AVDR for referral to domestic violence specialists and resources in the community. And this is why I always push for posters to be hung up in every provider's office of where the locale is for a hotline number and to be referred all referrals are in confidence. In my practice, even if the patient answers no on my profile, I still will offer them social services, and all of you should do the same. They can answer no, but it may not be what the truth is. If you offer everybody, you cannot go wrong. Again, it is better to have false positives than false negatives in the determination of an IPV-related injury, present, past, or some other type of abuse and neglect. My own research in this particular area, as I said, I've been doing this for over 20 years, was done during my time at Harvard School of Dental Medicine and Massachusetts General Hospital. I was on a fellowship from the Oral Surgery Foundation, and I co-developed a diagnostic protocol to diagnose victims in the emergency room and dental school clinics based upon 2 risk predictors, which was injury location, head, neck, and face, and responses to the partner violence screen, which is a highly validated tool used in many emergency departments. You can take these 2 risk predictors and add them into your own health history. You can change the orders of the questions. You can make it a point of writing if you feel uncomfortable in answering these questions. You do not have to, but it is always good to have questions in your health history. Mine were based on the partner violence screen with injury location. Have you been kicked, punched in a relationship? Do you feel unsafe in your current relationship? Have you had past feelings of being unsafe? An affirmative response to any of the above questions was considered as a positive for the likelihood of an etiology of intimate partner violence exposure. Through this model, we were able to develop a predictive model that we have used at Harvard. We've used it at Meharry Medical College School of Dentistry, where I spent my time, and now I am doing it at the University of Utah School of Dentistry. The predictive variables were found to be age. The older the age, the less likely a victim. The younger the age, more likely. Race, when compared to Caucasian, other was 3.7 times more likely to be a victim, and risk based upon injury location and answers to the partner violence screen. And this predictive variable has held true, those of you who are statisticians, with internal validity, external validity, and I'm looking for generalizability now across the board. And I'm hoping that we will see that with further testing in multi-centers. Again, you can use these kind of questions in your own history and questionnaire in your practice if you don't already have one. I suggest you not to use the question, have you been a victim of domestic violence? Because 9 times out of 10, or maybe 8 times out of 10, they're going to say no when the answer is yes. So, getting back to other risk predictors that may be apparent in those that present years later, we can have victims with obvious trauma versus those without. We can have victims who are already presenting with long-term negative health consequences, and how do we know that? And we can have victims with chronic illnesses. So one of the comments that I've said in the past is, does violence and abuse affect the lifespan? And how do you pick it up on your health history? Even if you get the no's, how can you still determine, well, maybe, even though those were no's, there could still be some type of traumatic stress-related event that is now manifesting itself in the patients that you are seeing. You remember this picture, why can't anyone figure out why I feel this way? So looking at the rest of your health history, can you pick up that this person may be a victim? Are you improving their health after exposure to stress from trauma by knowing this? Can you play a significant role in their improvement in respect to their oral and overall health? And what do you hope happens when you identify or refer individuals for intervention? Now, again, we're not going to solve all these problems, but using risk predictors in relation to poor health can also make you a hero or heroine in identifying a victim, even though the abuse may have happened years ago. Well, yes, you can. So why do I say that? Well, chronic illnesses, why is this a true risk predictor? Why does it manifest itself with the exposure of abuse? Well, it has a physiologic basis, and this has been looked at by Dr. Vincent Folletti, who is a pediatrician, and he published this model in 2002, and it's still being applied even today. He showed a relationship between medical conditions and abuse by looking at brain consequences of the early child abuse and trauma. Across the brain is part of our nervous system, and our nervous system is affected by the environment exposure, genes, and sexually dimorphic cascades that are controlled by hormones. We know this, we've learned about this, we've gone through puberty, we see that this can affect behavior and it can affect physiology. The neuroanatomic areas can be affected by adverse events, even occurring early in childhood. This adverse events can lead to chronic repeated stress by exposure with clinical, functional, and behavioral consequences. So if we look at the brain, we look at how abuse, incarceration, mental illness, substances, neglect, sexual abuse, physical abuse, abuse by the mother either to the victim or by the father to the mother with witnessing, separation and divorce, all of this has neuroanatomical consequences resulting in the effects of chronic stress. And chronic stress, if you remember from your basic physiology, has its origin via the brain pituitary endocrine axis. So the exposure to intimate partner violence can result in a dysfunction in neuroendocrine cascades. We know the hypothalamus releases neurohormones that act on the pituitary that produce cortisol. Cortisol can act on organs producing inflammatory mediators, and all this can feed back at each place along this axis. The hypothalamo-pituitary adrenal axis produces corticotropic releasing factor, arginine vasopressin, adrenocorticotropic hormones, glucocorticoids, serotonin, substance P, others that can cause arousal, angiogenesis, appetite suppression or increase in appetite, vasodilation, cardiac effects. And as an aside, I have done a study using saliva comparing cardiovascular disease markers to women exposed to IVP versus those who haven't, and I found a trend of significant increases in cardiovascular mediators causing cardiovascular damage in women exposed to intimate partner violence. It's one study that I have done, and it's in the list of references, and I am in the process of looking at that further because, again, as an academic surgeon, I am interested in the effect of abuse on total body function. But this is very important for you as a provider because you may see on health histories certain diseases that the patients have within those chronic illnesses that I showed you earlier, and it should send up bells and whistles. Not to say that every patient who has these diseases have been a victim, but it should be brought to your attention to think about it. The consequences of lifetime experiences of violence and abuse had been looked at by the National Advisory Council that I served on, and our colleagues across all medicine came up with what is referred to as the COLEVA, or consequence of lifetime experience of violence and abuse diagram, which is a very large octopus. But if you look within this and more consequences, you can see that exposure to violence and abuse affects every physiologic system within the body and can manifest further disease and health consequences affecting the lifetime of victims. We can look at dental, where we see, and this is at 8 o'clock, TM disorders, bruxism, increase in other parafunctional habits, poor dental hygiene, other types of dental problems. Autoimmune disease in women can be exacerbated by abuse. Other types of GU problems, neurological problems, etc. Cardiovascular disease especially, which is something that I looked at since cardiovascular disease is the #1 killer in women in most cases, and the oral health care provider can be very pivotal in diagnosing this by relating what he or she is seeing to possible traumatic stress-related events having to do with abuse. Something to think about. So the American Dental Association, the American Medical Association, and the Academy on Violence Abuse have developed an ideal strategic plan that is now still being looked at, looking at the effects of violence and abuse throughout the lifespan of victims and developing a trauma-informed care collaborative. And this trauma-informed care collaborative needs many more oral health care providers on it. We want to enhance the well-being of children, enhancing family well-being, partnering with families and services and other agencies to develop long-term health-related intervention of victims to raise their health-related quality of life and a more healthy society. Even though you're out in the community, you can get involved with your colleagues through continuing ed and collaboratives to allow you to play a very vital part in this. The Academy on Violence and Abuse came up with a set of core competencies for oral and overall healthcare interaction, looking at the healthcare system, the educational institutions, and the individual learners. Who are you? Again, I mentioned this before, but I suggest you go on the Academy of Violence and Abuse, ava.org website to learn more about this. There are some very exciting tutorials that are too long to discuss here, but can play a role in your role in greater identification of victims. There are teaching strategies by changing the learning environment, and we're going to look at this a little more closely in a moment. Our educations need to be standardized with courses like this that I am giving you today. Patient interactions, we have to be able to communicate better with our patients, and we learn this from looking at standardized templates, protocols, webinars, and DVDs. Have you ever been hit, kicked, or punched? Because difficult relationships can cause health problems, we're asking all of our patients, does a partner or anyone at home hurt, hit, or threaten you? There are different ways that you can ask these questions to develop a better therapeutic alliance with your patients to get the answers that you need. Research, of course, of those of you that might be interested in learning about research or the research that's going on in respective institutions. So changing the learning environment then, we want to bring out to our oral healthcare colleagues not formal formats or formal lectures, but maybe inviting speakers from the community. Again, you have the choice of using certain computer approaches that I described. We want to develop a standardized template that you can utilize, and that's really your choice in your health histories. I use injury location, other risk predictors, and questionnaires. Again, asking is an intervention. You must acknowledge and believe, you must communicate, it is not okay that you are being abused. You empower your patients by providing access to resources when they are ready to go. Again, as I said, I give everybody an option with a card to seek care if they are interested, even if they answered negative on any of my questionnaires. Remember, looking at health history, that you must make a connection between those histories and previous symptoms that they may be feeling. Why am I feeling this way? Because this can help them feel that you are eliciting a significant therapeutic effect. Chronic illnesses are the new risk predictors, if you do not know that. Education needs to be incorporated more in our training environments. Those of you that are part-time clinicians at either Roseman or the University of Utah School of Dentistry should remember this and look to see at the schools what the dental students are learning. They are our future legacy, and you can make a very big impact by affecting this. By doing so, you will integrate knowledge and systems into your own practice by promoting identification, care, safety, and support for patients and staff. It is so important that you remember that your staff can be victims themselves in relationships now. And, you know, are they absent a lot? Are they always complaining of pain? Do they look unkempt? Has their appearance changed, etc.? This can give you clues. The ideal cure is something we all hope for, but it's far away, I think, still, because again, there are so many barriers to people feeling comfortable about identifying. We want a decline in morbidity and mortality. We want to improve awareness of health consequences. We want to improve recognition and eradication. We want to have a very significant decline in frustration of our professionals because they think that these patients are difficult patients. We want to prevent an inappropriate use of medical resources. I showed you that with the cost. By doing so, there'll be a reduction in financial drain, and we want to ultimately allow for a better health-related quality of life for our community. And those of you that are ADIA members, we are looking to develop new curricula using different algorithms. We're looking to develop more faculty development courses. We want to look at better non-invasive approaches. I see saliva as a future in diagnosing certain characteristics that may predispose patients. And each dental school will be registering data in a national registry with the hope for a cure of this problem. Some resources, starting from the right, is that AVDR tutorial that you can look up and possibly still order, going on the AVA website to get those core competencies, going to the CDC. They are always updating on their website, preventing intimate partner violence across the lifespan. They have a wonderful package that is very interesting reading for those of you who are interested. Those of you that I showed the Utah poster to, you can go there and get a copy of that too, with all numbers that will help you. And I thank you for this opportunity of letting me take your time to teach you and supply continuing ed. It is something that is worth further discussion, and I look forward to your comments. I gave an in-depth list of references, but at the bottom is my email and office phone number for you. So I thank you for your time. I wish you a lot of luck. I hope that next year I can meet many of you in person. Thank you again, and please stay safe and healthy. Good day.